continuing in our theme of recent Scholar of the Year completers, we have Sheena Kalagara, who's going to be presenting a case of a pituitary adenoma.
Thank you, Dr. Morganson. Hi, I'm Sheena. I'm presenting on a case by Dr. Patterson, and the title of my talk is titled Pituitary Adenomas, Diagnosis and Management. So the case that I'm presenting was of a 74-year-old male who had a past medical history of atrial fibrillation, hyperlipidemia, hypertension, type 2 diabetes, and he initially presented to an out-of-state center with 4 episodes of disease. The initial imaging showed a 2.2 centimeter pituitary mass with optic nerve contact as seen in the imaging here. Now, when initially characterizing this mass and the initial workup, there are several classification systems that will be important to consider. The first one of which is size, and we can differentiate between macro versus microadenoma with the differentiating factor being 2 millimeters. Looking at endocrine function to see if the mass is secretory or non-secretory, and next looking at the presence of invasion, which will help guide the approach and predict the rate of resection. Going into this a little bit further, the lateral invasion has been classified using the NOS criteria classically as a marker of potential resection. However, research done by our group here has shown that potentially using volumetric 3D imaging might be a better marker for gross total resection than NOS criteria. That these invasion predictor scales are constantly evolving. Additional workup has included an endocrine assessment and also visual field testing. For this patient in particular, they denied symptoms of endocrine dysfunction and visual changes, but on ophthalmology workup, they saw bilateral ganglion cell layer thinning, which will kind of play into effect on how we choose to treat this lesion. So here are the following management strategies that we could potentially consider here. The first being medical management, which is usually for prolactinomas, surgical management, radiation therapy, or observation. However, in this case, because we saw contact with the optic nerve and the deficits noted in the ophthalmic workup, we chose to do surgical management. Now, when looking at the surgical approaches for this lesion, the first decision that we should make is whether we will do a transcranial approach or a transsphenoidal approach. There's been a lot of research kind of looking at when to go with each approach. And while transsphenoidal approaches have become increasingly popular recently, research has shown that in cases of large pituitary tumors, such as those over 4 centimeters that have invasion, a transcranial approach may be indicated. And there could also be a role for a combined or staged approach using both techniques. So that's 3 key questions that we can use to kind of guide this decision making are, what is the size of the tumor? What is the level of invasion? And are there any patient characteristics that need to be considered? In this case, it was a 2.2 centimeter macroadenoma that was relatively confined to the sellar region. And this was found in a patient who was older with significant cardiac history, who might benefit from a more minimally invasive approach. Taken together, we went ahead and chose the transsphenoidal approach in this case. So after making that decision, the next big point is whether we should choose a microscopic approach or an endoscopic approach. Again, there's been a lot of research looking into both of these. Traditionally, the previous gold standard was using an operating microscope as it was associated with minimal morbidity and mortality. But more recent research has shown that an endoscopic approach might be associated with similar rates of complete tumor resection with potentially fewer complications. And I just wanted to highlight this recent prospective multi-center controlled study, which looked at comparing these 2 approaches and found that while they had similar rates of gross total resection, there was increased incidence of hormonal deficiencies in the microscopic group. So kind of taken together, this kind of supports the transition to an endoscopic approach. And this kind of highlights the surgery that was performed here, which was a transsphenoidal endoscopic resection of a non-secretory macroadenoma of the pituitary gland. Looking into the specific approach details here, we initially placed the patient in a sniffing position with slight neck flexion, and we can employ head fixation to improve the efficacy of any neuronavigation, which is going to be based on preoperative brain contrast MRI and CT imaging. So the initial approach and exposure was provided with ENT to the sphenoid and sellar spaces, and they also utilized this navigation to allow for targeted bone work to go ahead and gain access. So the key considerations that we need to make is that this is a very critical area which is surrounded by a lot of neurovascular structures that we need to be mindful of when resecting this tumor. Some technology that we can use here is Doppler ultrasound to locate critical vasculature, such as the carotid arteries. And prior to closure, we need to assess for proper hemostasis and the need for dural tear closures if we do see any presence of CSF. So in the postoperative setting, there are several key considerations that we need to make. The first of which is key labs that we need to take and symptom monitoring. The first of these is an endocrine follow-up to look for a DI watch and an endocrine panel to assess for any abnormalities that we might see in the postoperative setting. And the next will be visual field and acuity testing. Looking at some research that our institution actually did on postoperative vision loss with this endoscopic surgery for pituitary macular adenomas, there were several factors in the preoperative, operative, and postoperative time points that we need to consider when both looking at things to expect for the patient, also informed consent during the preoperative setting. So factors that are associated with postoperative vision loss in the preoperative setting include visual impairment and optic chasm compression. And then for the surgical factors, if you have a need for graft placement or if you open the diaphragm with thalli, and postoperatively, if there's an immediate postoperative hematoma or any graft herniation noted. Next, we'll have to complete postoperative imaging to assess for any residual disease. For infection prevention, we need to consider any prophylactic antibiotics. And then we need to have a consideration for looking for possible CSF leaks and utilizing the maneuvers listed here to potentially prevent increases in ICP. So kind of throwing this back to the case at hand, we did not know any major endocrine abnormalities or visual changes. For the post-operative imaging, we completed the imaging here, and you can see that there is potential residual disease versus possible surgical changes noted in the dissection cavity, and this will need to be followed up with imaging after these immediate post-operative changes resolve. Next, for infection prevention, we went ahead and went with prophylactic augmentin. And then none were noted, no CSF leaks were noted during the surgery or in the post-operative period. We will have a low threshold for observing this. I wanted to thank the neurosurgery team, Dr. Patterson, Dr. Fang, for all their work and comments on my presentation, and also our collaborators in the ENT and endocrine department. Thank you.
Thank you, Sheena. Nice presentation. It's good to organize yourself like this for the common cases we do. You laid it out very nicely. One of the things that has not been emphasized as much as I see it in my patients is the nasal, I guess you'd call them the nasal and pharyngeal symptoms caused by an endoscopic approach, and the amount of tissue that's lost, the long period of therapy that's needed to get them back in shape. I'm convinced this is a very different experience for our patients, but I haven't seen much written about it. And there is a trade-off, but you really get a better exposure, and I think we get a much better. It's easier to get a good resection, and we have almost no CSF leaks with the endoscopic repair and the team, the way they're doing it. What I've also begun to notice is that the ENT team and the ENT approach are quite different. With some of our ENT surgeons, they have perfected the art of a minimally invasive endoscopic approach, and those patients seem to do better. But that was a very nice presentation. Raj, do you have anything to add?
Yeah, excellent presentation, Sheena. Very well organized, and I think you hit all the salient points. I think, just as Dr. Betterson was saying, there's been an evolution in the practice of endoscopic surgery, and I think that it's worked, and I believe it's worked organically in a way where we both learned, we meaning the community of surgeons have learned to tailor the dissection that you do, the extent of the bone work you do, to the disease and to the degree of resection you want to obtain. A plain meningioma is a different dissection and drilling than it is a more traditional pituitary tumor, and has different considerations regarding repair. And I think it all actually adds. And the Pittsburgh series, who were the